Okay, I already know the answer to this, but have you ever watched the helicopter take off from the hospital?
Absolutely. Every time.
And it's pretty mesmerizing, right?
Yeah, it captivates you.
Do you ever wonder, like, what is the situation? Like, what is the situation with the baby or the child that they're going to get and that they're going to be bringing back to Cardinal Glennon?
I do. I mean, like, I know it's important and could be scary and dangerous every time Glennon 1 is dispatched and going out to retrieve a patient. But I try to force myself not to think too much, because then I'll just be thinking about it all the time. Usually the things that go through my brain, though, at that point are just like, God be with them, because I don't know what's going to happen.
Yeah, for sure. I always find myself, I mean, it's not that often. I don't get to see it that often, but I always find myself saying a prayer when I see one of the ambulances taking off or see the helicopter take off. And, I'm saying a prayer for the staff that are on the call. I'm saying a prayer for the family of the baby or the child. I mean, can you even imagine handing your baby off to total strangers?
No.
And then I think about the staff, and they're all highly trained in critical care, right? But they're doing critical care on wheels, or in flight in a very, very cramped space, which is entirely different than critical care in the hospital. And not only that, but like in our critical care areas, there's teams and teams of people at the ready, right? To support you. When you're in the ambulance or you're in the sky, you have like one other person, to rely on. You don't have the code team button, or you don't have, all of those others, that whole support network. I just feel like it's a lot of responsibility.
It's a ton of responsibility, and it's probably why they get to wear those really cool special flight suits that we see them in, right? Like every time, like if we're walking into work in the morning, like I see them coming in from the parking lot, I just kind of hear in my head, the Highway to the Danger Zone by Kenny Loggins that was in the Top Gun movie.
I don't really know that that's why they get to wear those suits, but honestly, when we were thinking about this, I realized how much I don't really know about the work of our transport team. For years, I used to think that they were the 911 people, like for real. Like if I had an issue at home and I called 911 for my child, that it was those people. Like it was our transport team that somehow, some way, I don't know how the universe made it happen, but that those were the people that would come, to save my child. But I worked here for a whole lot of years before I realized that no, that's not what they do, that they actually do inter-hospital transport. Did you know that our transport team services 120 different hospitals?
Wow.
Yeah, within the bi-state and beyond. So they're going out and bringing babies and children here who need our level 1 trauma centers, who are at other entities that don't have the level of support that these kids need. And I also didn't know that at the hub of that, or the core of all that service and inter-hospital transport, that we have an access center who is like central intake, that they manage all the calls and then kind of farm out what's needed to get kids where they need to be into a higher level of care.
What a complex coordination effort that team gets to do every day.
For sure. They're definitely rock stars and responsible for those minutes that matter, right? Really down to minutes in a lot of cases.
I mean, I have a lot of questions for these folks too, and I don't get to really interact with them very much, but our transport team, we've got the ambulances and we've got the helicopter. Like, how do they decide which one to take? And who are the people that go on the trips? Like, do they bring a doctor? Is it just a staff of nurses? Like, who all gets to go on these trips?
Well, it's really evolved. I know that much through the years. This team has really grown from just having just a neonatal team back in 1979, which, by the way, we had the very first neonatal transport team in St. Louis. So they've grown from just that to having a pediatric team that was added in 1991 to now having one big combined team and 3 bases that they operate from. And the people involved are paramedics and respiratory therapists and registered nurses, and they all have advanced training in stabilizing, treating, and transporting babies and children. And we are going to have today on our podcast some boots to the ground people who have tons of combined years of experience joining us to help answer all of our questions and what might be things that other people are curious about learning too about these people in the fancy suits.
I really hope they get to answer my most burning question of all, though, which is who gets to drive?
It's not me, thank God.
Well, let's find out.
Well, welcome everyone. Welcome, welcome. We're going to do some introductions. Let's have each of you say your name and your title as it relates to the transport team.
My name's Judy Cowell. I'm the manager of the Access Center, and it's neo-peds, maternal, and we work closely with the transport team.
I'm John Peter. I'm the medical director of the pediatric component of the transport team.
I'm Jeff Wynmiller. I'm a flight paramedic on the transport team.
And I'm Dana Rowland, and I am one of the nurses on the transport team.
Awesome. Well, we know you are a small handful representing many, many, many colleagues that are part of your team. And we're going to learn more about each of you, and we're going to dive into the work. But first, we like to do little icebreakers just to get everybody comfortable. So we picked a fun one just for you. Are you ready? Okay. So when you're on a trip, there's only a couple of you, and you're very, very dependent on one another, right? To have a successful trip, and you have to know each other's strengths and really depend on each other, right? Okay, so I'm going to ask each of you the same question. If you are stranded on a desert island, which one other person out of this group would you want to be stranded with, and why?
I would pick Dana. Dana's an expert at the beach. She's always
Did we
on
say
a
it's a beach, or is it a
Well, if
It's a desert, there's sand.
Islands
She's
have
always
beaches.
on the beach.
Okay.
Yeah, I'm actually leaving for the beach in 2 days. So.
Oh,
Congratulations.
I'm so jealous.
Yeah.
Okay.
I would probably pick Dr. Peter, just because he and I have been in this since the very beginning. So I just feel like we know each other pretty well, and he knows that I don't hesitate to tell him what to do most of the time. So I just tell him what I'm gonna do. So
I'm going to emphasize that you're stranded. There's no other people, and you want to get off the island. So
yeah, I think we could.
I think
work
y'all
it
are
out.
thinking you're just going to hang out there and vacay for a while, but that's okay.
I think I'd want to be stranded with Jeff because he is a paramedic, and that was a new role to Glennon. And I mean, you taught me all about EMS outside world that I did not know. He travels to Hawaii so he could help me get off some island.
There you go.
And no, just the knowledge and just I've worked with him for 10 years, so it's been awesome.
Be able to make a splint out of some palm
Yeah,
fronds,
yeah.
probably.
Yeah.
Yeah.
I love that.
Probably Dana. And for the same reasons. We've been together for a long time to this, and she'd figure out a way to get us off there. Yeah. As a physician, I'm pretty useless for that stuff, but the practical component of it.
You could carry the bag.
Yeah, I'll carry
Yeah,
it.
yeah,
Yeah.
exactly.
Get the sunscreen.
Yep.
I absolutely love this because you had no hesitations. Like, you really did not even have to think about that. Like, I feel like if we were doing this in our group, I would be so self-conscious about like, oh my God, well, what if I say that? What if I pick this person and this person's going to feel this way? And I think that's so representative of you cannot have egos in the work that you do. I mean, you have to know your strengths, but you know, I just,
Well, and you
I
have to
don't
make
know.
quick decisions too in what you
Yes.
do.
I love it. There's so many years of experience here in this room and so much critical care experience. But I think to understand who you are and what you do, there are people listening that have no idea what the transport team is. And I think just with the same fascination that you guys as young people would watch the helicopter and watch. I don't know that you fully had an understanding of where they were going, what they were doing, what the job was, so on and so forth. So I think for our purposes here, we absolutely need to start with the basics. So Dr. Peter, you're on. I would like you to explain to our audience, what in the world is the transport team? Why do we need it? What is the goal of the service that you provide?
Okay, so the transport team is composed. We'll start with composition. It's composed of nurses with this critical care experience, and paramedics, and respiratory therapists, and in extreme situations, we can put a doctor on those trips too. The reason you need these teams is, as much as we wish children who were sick or injured would always come to a children's hospital, about 80% of the time they show up in community hospitals. So you bring a sick or injured child into an environment where everybody is, most of the people are not very comfortable with taking care of children. It scares them to death, much like an adult with chest pain scares me.
Right.
Okay. And so, this child is sick or injured. They do the best they can, but they clearly need help. And so they contact Judy, and there's an exchange of information that goes on there. A team is kind of rapidly put together. It's composed of the appropriate people that are needed for that trip. And then decisions are made as to how to dispatch those teams, whether they go by ground or air, and off they go.
So it's not like a 911 situation where you all are going to like the scene of an accident or an incident to get a patient. This is strictly hospital to hospital transfers.
No, in those situations, you really need a unique skill set, and medics have that skill set. We shouldn't be doing scene flights. That's not our area of expertise.
So how in demand, give us a scope, I guess, of how in demand this service is. So in other words, like how many times are you making these trips, like on average on a year? How many trips are you making, and like how far out is a community hospital? Like how far is our reach? How far are we going to get kids back here to Glennon?
I mean, we've sent teams to multiple states in the country. Generally, we reach out about a 200-mile radius. And numbers-wise, I think on average,
it's like 1,600 to 1,700 between neo-peds. And then we also do the maternal trips with the nurses from the transport team at St. Mary's.
I did the math. It works out to not quite 5 trips a day.
That's a lot of trips.
Oh, sometimes
That's
it's more than
I
that.
thought.
Yeah. So
That's just
if you averaged it out, that's what it would be.
Yeah.
Some days are crazy. We can't keep up, and other days we all just sit.
And we joke in the Access Center. I'm sure the team doesn't joke about it since they're going on them all. But, we count the record of how many in a day. I think it was 13 or 12 in one day. I'm sure they didn't feel the same way, but we were like, wow.
Yeah, I can guarantee
Yeah,
I'm
sure
we're
you
not feeling the love.
Yeah. Not that day. Yeah. So Judy, you mentioned the Access Center. So I feel like the Access Center now, current day, is like the hub, right, of all this. This is where everything begins and where everything is farmed out. So I think, and there's a lot of people that have no clue. People are just making a call. Like most people don't know what the Access Center is. So can you explain what is the Access Center and talk about your team and what they do?
Yeah, I think the hub is a good way to describe us. We're sort of the first entrance into Glennon before the transport team. So the Access Center is comprised, like I said, it's all registered nurses. And their experience level, I think the combined current state of my nurses' experience is 32 years. And that's like the average. I don't think that's the average, sorry. But I'm fortunate now that they're all pediatric and neonatal trained. So that really helps in the role. They need high triage skills because we are the ones that get that initial information. So it's not a nurse line. That's a lot in the past. That's kind of been construed as a parent could call. We could tell them whether to go to the ER or not. And that it's not that role. And we had to do some work to kind of evolve that so that they knew it was really just that outside provider. So we get calls from physician assistants, nurse practitioners, obviously MDs, calling from hospitals. It could be another SSM hospital. It could be another hospital out of the system. And the reason they're calling is, as JP brought up earlier, a lot of those hospitals aren't used to taking care of kids. And so we treat a lot of rural hospitals, small, maybe, three beds in their ER, something like that, that small. And so when a kid comes in, it's all hands on deck, and they're just not used to seeing it. And even some of our pediatricians that have gone on in the world who've done their residency at Glennon go to some of those smaller hospitals. And it is something to say that until you experience a hospital that doesn't have the resources that we have at Cardinal Glennon, it's very hard to understand. We ask for something at the drop of a hat and we get it, or we've got all the tools we need in our bags. But at those hospitals, they don't have that, so they're reaching out to us because we are the experts in that field.
What an incredible service, though. Like, I'm thinking about back in the day, I mean, for real, I mean, an outlying physician would just like kind of blindly send this family to Glennon, right? Or they'd be on the phone forever trying to get through to a specialist or a provider, and what a wonderful streamlined service to be able to offer that. And it just cuts down on all the junk, right?
Well, and it's also nice because we still hear that today. Oh, it's so nice to call one number and be able to get, who we need. I tease John because when we started this, he was like, oh, we didn't take that many. I mean, you won't get that many calls. And I worked the first night that it happened. And I think we had 2 transport calls that we had to go through this new process because they would handle all the transport calls before if it was pediatric. And I was just like, really? Of course this would happen, and then everybody calls. But that just tells you how needed the service was.
Like, it just makes sense.
Yeah.
And I feel like it's so funny because people coming into this world now, it's just there. Like, people have no idea how piecemeal and how disjointed it probably was before, but it's what you did. Like, it's all you knew, right?
So we talked about how many transports we do a year. How many phone calls do you guys handle?
About 90,000 calls
a year.
90,000.
Wow.
It's about 11. So that you have to keep in mind with the calls, it's us out, them calling in, that kind of thing. So maybe a different way to look at it is like around 1,100 cases per month. So, because it comes out to be about, I think it's like, I can't remember how much it is per day. Well, I can't do math that fast, but it's a lot.
It is a lot. If you think, and that's just coming from the community physician, right? That's not, to your point, it's not patient families calling in saying, what do I do?
I mean, roughly every patient that transfers, I'll just use this as an example, takes my nurse about 90 minutes to complete from step 1 to the end where they're accepted. So it's a lot of time spent on each transfer. And we've developed a relationship with the community physicians. It's one of my favorite things is, I listen to all of our calls are recorded, so I'll listen to some of those. And sometimes my nurse will answer the phone and I'll hear her say, hi, Dr. So-and-so. And, they say the same thing back. Or when you're answering the phone and you say, this is Judy, they'll be like, oh, I haven't talked to you in so long, So that's kind of one of the fun things to be able to watch is just the collaboration and the rapport that develops between the community and my nurses especially.
Well, it seems like the transport team in whatever iteration has been around for a while, and you've got some amazing years of service and experience that have built up to it. Were there, like you said, there's like a constant evolution for always making it better. And I know you've alluded to kind of how you just made it work because you had to in the past, but were there kind of some key milestones over the timeline of getting it to that evolution? Or was it just like a continuational process of how do we make this better? How do we make this better? Can you kind of give us, and like if anybody also, if you have any examples or stories of what, if anything, made it to where we were like, how can we make this better?
We would get these calls from these community hospitals with these really sick children or severely injured children. And while we had a neonatal team that could transport the babies, we didn't have the team available to transport the children. And while there were air services around that could transport the kids, we just wanted a better way to get them to us, because it does go back to, once again, like Jeff was saying, as a paramedic, kids terrified him until he started working with them all the time. So this was an opportunity to get the care to those kids sooner, and with the expertise of people who were specifically trained to take care of kids.
If I wanted to be one of you when I grew up, okay, what does that look like? What kind of experience do I need to bring to the table minimally? And then how do you train me to be one of you? Does that make sense?
Yeah, it's a 3-year for any discipline, respiratory, medic, or nurse. It's 3 years, and the preference is critically care. If you take it all the way down, it'd be if you had neo or peds. But as healthcare has changed, and the nursing shortage, the medic shortage, just all of that, they've had to look outside the scope of just our traditional. There was a time when if you were an adult nurse, even if you were critically care trained, you probably would not be chosen to be on the team, because we were looking for a specific skill set. And to be honest, we used to have pools of people who would apply. I remember when it took me twice. First time, I didn't get, the second time I got picked because someone didn't finish orientation. But there was just that much interest. And I think then bringing on the paramedics was just another whole skill set that we had to learn about. So yeah, Jeff.
Yeah. So as a paramedic, I think the paramedics that do best have worked somewhere that they're doing ICU level transfers. Mm-hmm. And a lot of those people come from the flight paramedic world. And as a street paramedic, you'll have an occasional child or neonate, but you're not specialized in that. I came from critical care, adult flight job, and it took me a long time to become comfortable with children, with the neonates. One thing I think is really interesting is, Cardinal Glennon, how many beds do we have in the NICU?
Now?
Yeah.
It's like 75, I think.
And they all come in via our transport team.
Yeah.
Mm-hmm.
Yeah.
Mm-hmm.
So we have exposure to babies constantly.
Yeah.
But you wouldn't have a job if you didn't have critical care experience to begin with. Respiratory therapist.
Same.
Mm-hmm. They need ICU experience before they're considered.
And I think just knowing Jeff for so long, I learned so much because I had never worked with a paramedic. So with the paramedics we had when we first started, I think probably one of the biggest culture shocks for you guys probably was going to a hospital environment where you have hospital guidelines. It's not like street, and just the protocols, guidelines, all of that. I can't even imagine what that felt like. Probably felt like me going to peds, like cross training. But I just knowing you guys for so long, that seems like the biggest, I think probably biggest adjustment in addition to learning. Yeah. In addition to learning the patient. Talk. Yeah. Yeah. Cause that wasn't something they normally do on the streets. They don't call every time. They have a list of guidelines, right. And protocols. I learned a ton from them though, cause I'd never worked with paramedics. So I think that was just a general progression of the team. One thing I was going to say, when we first started neonates, we would pick up 60 babies a month, 65 babies a month. And as healthcare has gotten better, the babies are not born. I mean, they're still born small, but some of those hospitals have learned to treat them better. We've seen a flip in that. And so now we're more like 90 to 100 pediatric trips a month and maybe 45 neonates. Like it's done a complete flip, which leads to needing the different specialized, like bringing on the paramedics. Put me with one of them on a trauma any day, and I'll be like, okay. I'll sit back here because
Right.
I love my babies. But
Well, and speaking of loving the babies, I'm imagining that, okay, so let's say I come to the table and I've had 5 years as a NICU nurse, right? But I've never done not NICU, right? And I'm going to be doing some 18-year-olds too. So I imagine there's some cross training or some shadowing, yes, that goes on during the onboarding. So like, okay, Jeff, you never did kids. You were terrified, right? So I imagine there's some onboarding, shadowing, whatever that calls. So what does that look like?
Well, part of the orientation process is to spend some time in your non-familiar area. So, for example, someone with only neonatal experience, they're going to spend some clinical time in the emergency room, in the PICU, and then vice versa. You know, I had no NICU experience, so I went when I cross-trained and spent time in the NICU. So we have a very intense orientation process. Generally, you know, it's kind of fluid, just depending on basically the exposure that the orientee gets. You know, we've had people that they just can't seem to get the trips they need while they're in orientation. So we've had to extend the orientation. But as a general rule, it's about a 3-month orientation process. As I said, you spend clinical time in the different areas that you are not original to. And then there's just a lot of, most of it is just on the job training. There's really no other way to do it. But learning the equipment, you know, our ventilators and all of our ventilator management. We transport with nitric oxide. And so that is a skill that, you know, we don't use it very often, but we still have to be able to do it. And even things as simple as IV therapy. You know, if you've got someone that only worked in the PICU and now they're coming to transport, you know, nurses in the PICU, generally their IV skills are not as good as, for example, someone who works in the emergency room, because in the PICU, so many of those patients have central lines, and the same way in the NICU. So just even becoming comfortable with IV therapy is, you know, a big skill.
One thing these guys haven't mentioned, and it's a big part of what they do, is people skills. You know, they are used to working with doctors in an academic medical center, and there's a free flow of information back and forth. There's an interaction that occurs because that's just what academic centers are like. And then you go to a community hospital with maybe a very seasoned senior physician out there who now is confronted with a nurse and paramedic or a nurse and respiratory therapist telling them what needs to be done. And that can be, you know, a challenge once in a while, having that conversation. And being able to come in and take command of a room, include the people at the referring hospital. That's always a positive response we get on our trips, is like, they were really helpful. They taught us a lot. They kept us in the room so that next time a child comes in that's sick, now we kind of know what to do. So those people skills are really important. Sometimes you have to just sort of swallow hard and say, let's just go and we'll make the changes when we get in the truck. Okay. Yeah. You know, we've had those situations where physicians just said, no, you're not doing this to this patient. And they have to just sort of, okay, fine, and adapt. And that's a big part of their skills. And they're not talking about that, but that's a big part of it.
But that's a lot. I would guess that's a lot of on the job training kind of, right? You know, like you learn. I mean,
you're the face of, and when I first started transport, that's what was told to me. You are the face of Glennon. So if you don't have the people skills, or you make somebody angry on the outside, you know, that's a possible, that patient is potentially there for life. You know what I mean? Follow-ups and clinics, and it's true. You can definitely change a referral pattern, or which seems interesting that they're so powerful as a team. But, you know, it's just courtesy in how you present yourself to the other. Because they don't, you know, a lot of those hospitals, that's why they're calling you, is because they don't have the resources. So that is a huge customer service is a big component.
Yeah, taking care of families
Yeah.
is another component. And I don't know that we have any formal training on that, but realizing that, people aren't as fortunate to have, a vehicle for every family member or a vehicle at all. And, we have to ensure that we can get them to Cardinal Glennon to take care of their child also. I think if you live in the far reaches of Southern Illinois, it's a 2.5 hour drive. And if you don't have a car, what do you do?
Right.
Yeah.
So, and we depend on social work once we get to the hospital to figure out the other half of that. But, yeah. So.
But then also taking it into consideration when you have a family member who is maybe just a little too excitable or not in a good space, is that really someone that you want to put in the vehicle with you while you're trying to take care of their child? So one of the things that we as a team have stood pretty firm on, obviously there's always exceptions to the rule when needed, but we don't allow our parents to ride in the back of the truck with us. They have to ride up front. And it's, that is not always well received. A lot of families, they struggle with that. But we just feel like that is the better place for them to be, for us to be able to do what we need to do. Because as a parent, I think most of us here are parents. When that is your child, it is hard to let go of that control, because that, you still feel like you know your child best and you know what they need. So I think it's really, it's challenging that, Dr. Peter alluded to this earlier. We walk in and in 5 minutes, we have to develop that relationship with that family to make them trust us and be able to take their child.
Getting those people skills really finited there. I'm not a medical person. Laura has a lot of medical background, so she's able to speak to us. So I have a very non-medical question, but it's been burning in my brain. You've mentioned cross-training of skills from everybody who goes out on a transport. You've also mentioned that parents ride in the passenger seat of the truck. I want to know, who drives the truck? So do you have a designated driver for each of the transports? Do y'all take turns? Is rock, paper, scissors for pilot part of your triaging system? I gotta know, because I love helicopters. I think they're so cool. But how do you all determine who's responsible for getting everybody there and back?
So we have a group of, their title is operator. They're EMTs and paramedics, and they're assigned with the crew for the day. And when the trip comes in, it's a group effort. They drive, and that's led by Jim.
Mm-hmm.
And
they're non-clinical, so that that you have those separate from. They're part of the team, but you have your team plus an extra person.
Yeah, they don't do any medical care.
They're your plus one.
They are.
Yes, they are amazing plus ones. We are so happy to have them.
Yeah.
There's a future there's a chance in my future I could be a pilot or an ambulance driver.
And then there's we have 4 dedicated pilots to our team. And so that's nice, because in addition to the operators, you build a rapport you're always going through the 4 pilots. They do their own rotations, and you get to learn each one of them. And
so let's talk about the vessels for a hot minute. Let's talk about the helicopter, the MICUs, which somebody can say what a MICU is. We talk about PICU, NICU, MICU, all that kind of stuff. So let's talk about the vessels that get you guys from point A to point B. We have a nice little fleet between the helicopter and the ambulances. So tell us how they came to be, because we didn't always have them.
So I think the biggest reason we have what we have now was just as transport has evolved is the need. So when we first started, we used a private ambulance service, Abbott Ambulance, and we would have to call them to come and pick us up. That team did not provide any care. They were strictly there to drive us. And it was just, we would have to wait for them, and we just never knew how long that was going to be. We really liked to get out of the hospital 15 minutes if possible, but depending on how busy they were, and over time has evolved that EMS has shortages just like everybody else. So we saw those response times coming longer and longer. So that was one of the reasons we really wanted to go to our own fleet, was so that we would have more control over what that looked like. As far as the aircraft, when we first started, we worked with Archer Medical Services, and they provided our aircraft. But there again, we were sharing with them. So, they had to have an aircraft available to send us, and that always was not the case. So again, just more of a need that, thanks to our very generous donors who helped to provide those the MICU trucks for us, which MICU stands for Mobile Intensive Care Unit.
Thank you for clarifying that.
So, but we do still on occasion have to rely on an outside service to come pick us up if, for whatever reason,
if you have 13 in a day, or
or we don't have an operator for the day.
Yeah, sure.
And it's amazing how quickly you become spoiled. And, just again, now you're traveling with people you don't know again. And it's just so nice having our own people.
And these are not just here at Glennon. So you're spread out. So we used to just have Glennon be home base, right? Was home base for the team.
Everybody was here.
And now not so much. So now where's everybody at?
Well, as everything progresses, the need for having us in a more of a rural area, or an area closer so that we can get to those hospitals quicker. So that was 2011. We opened a base down in Cape Girardeau, so just about 2 hours south of us. We did it as a 6-month pilot, and I think by month 1, we knew that it was going to be successful because the need was there. They loved having somebody that was 10 minutes or 15 minutes, whatever we were away from them. And we were with that ambulance company that's down there. That's who we used at the time. Now we have one of our MICUs down there. They operate it, so they drive our MICU, the North Scott County Ambulance District that's down there. And then we have another base that's out at Spirit of St. Louis Airport. And what's great about that is the helicopter lives there, and the MICU lives there, and then a clinical crew 24/7. So you can go either way from there, and that's where we primarily do our flights. If they're out on a ground trip, then we can use our St. Louis team for that. And St. Louis is where the last 1 or 2 teams, depending on how we're staffed, are.
And what's the maintenance on these vehicles? Like, I'm thinking about my own little car, my little Ford Fusion, and the maintenance, and I got to replace that every once. So I'm not asking you like how often do you change the oil or anything
Jeff,
like
do you
that.
change the oil while driving?
We were so. I think we were so proud to help you get that fleet of, not we as in me, our donors, whatever.
You had a part in it,
to
Laura.
help fund. Shouldn't say whatever. But our donors were very proud to support that effort, right? But it's ongoing, I feel like, right? Like just like a car, you got to replace it,
it's
right?
constant.
At some point, right?
We are hard on things.
Yeah.
We do a lot of miles, and
so we're going to need new ones at some point, right?
Absolutely.
Okay.
So we have more than we can drive in a day, but when one's out for maintenance, then we'll use the other one. So it's important to have multiple. We're hard on. I don't know the miles.
I don't know what
significant.
It is significant. And the other thing to know, to the donors out there, is that it's not like a car. I'm going to go purchase my car tomorrow. An ambulance takes approximately 3 years, I think, to build and to do. So we're already, having to work on, because these are 3 or
We got these
3.
in 20.
Yeah, that's what I thought. So we're already on our 4th year.
It's a long
Yeah.
process.
You're in
So
the
it's not
planning
like you can just
stages.
It's
Yeah.
not like you can just go order your car. It's not.
Right.
You can't order an ambulance. It's a long process, and I know that they're starting because we need to look at newer ambulances.
I know people talked about like a 6-month waiting period for new vehicles a couple years ago because of the infamous chip shortage, but I can't even imagine a 4-year waiting period. So each one of those is a custom build just for Cardinal Glennon.
Mm-hmm.
I got to see, like, we got to see inside of the new MICUs back in 2020 when the fleet came in, and they are impressive. And I don't remember who it was giving me a little tour of like, well, this is the this and this is where the this goes. But can you explain to everybody kind of what you can expect to see inside of either the helicopter or inside one of the ambulances? Like, is it just preloaded with all the gear, or like how does that work? Like once you're out and gone on a trip.
So the ambulance and the helicopter, they both have cabinets, and we do have supplies that we could use in each of them. Primarily, we operate out of, we carry our bags with us. We have a bag with all of our airway supplies. We have another one with all of our IV supplies, IV fluids, whatever you could possibly need on a trip. Some of those things we keep duplicates of in the ambulance in case, if we drop one and we've only got one in a bag, you got to find another one. So we'll have that in a cabinet just in case. They have on board air and oxygen. We have suction.
TV or don't you have iPads or whatever?
iPads
for the kids.
A radio, the Bluetooth, so we can entertain children. That's probably that iPad is fantastic. You take a kid away from their parents and they're upset, and you ask mom and dad, hey, what's this kid watch on the iPad? And you put on their favorite cartoon or movie, and it's comfortable for them.
Distraction.
And,
Yeah.
We've all become very familiar with Bluey.
Yeah.
I might just say.
Yeah.
Is that the consensus favorite children's show, or do you all have a different favorite one that you get to watch on the trips?
I like having the older kids because then they watch things I'd be
sometimes
interested
movies.
in.
Yeah,
We can watch a whole movie on the way.
Yeah.
So
I find that fascinating though, like that you carry, like you bring most of your stuff with you. Like it's not on there, like there's compartments for you to store a lot of the stuff, and like the whatever, the lines, the gas line, the oxygen line, but a lot of the things that you need to care for the
portable.
patient are portable.
So our MICUs live outside in the weather. They do have some heating and cooling while they're parked. It's not ideal. So a lot of medical supplies are sensitive to temperature change and climate.
Sure.
So we like to keep our bags with us where we can ensure that stuff is always as, I guess, fresh would be the right word. So then a lot of the stuff you find in the ambulance, the backup stuff, it's like a ventilation bag, an ambu bag. That stuff's probably more tolerant of heat or cold than IV fluids or medicines. So we can keep those backups in the cabinets in case we need it.
So with the new, you guys have, so we have the helicopter, we got the new MICUs, but that's not all that's kind of also being evolved in the equipment spectrum. Didn't we recently get some brand new fancy incubators for transporting the neonates from hospitals? Can you kind of tell us about these new things? What's awesome about them? How big they are? I've heard they're kind of heavy.
They're terribly heavy, but they have
It's
to
all
be
heavy.
It's good. We don't want anything that would be easy to knock over.
Like how heavy?
Aren't they 300?
They're
or
more than
250?
300
Yeah.
pounds.
Oh
Holy
my
cow.
God.
So-
I could not do that.
No, that's arm day for you. Are you kidding?
Oh, stop. Okay. Okay.
So the new isolette, they have all isolates are heated, but this one has a heated mattress, and there's a tray that pulls out, and it makes accessing your patient, your neonate, much easier. It's much easier to secure them for transport. And I don't know if you guys have ever seen us when we have a baby in there. You have IV lines, you have all your monitor lines, and you would have your ventilator tubing, and all this has to get crammed into the isolate, the box. And the new one is taller. It has a bigger opening. It's more accessible. It's pretty fantastic.
We're one of the first transport teams in the country to have this isolate.
Wow. And is it used on both the ambulance and the helicopter, or just
Yes.
one? Yes.
Mm-hmm.
Yeah,
Okay.
we use it for both.
Okay, I'm gonna ask a really stupid question because this 300-pound thing is like waiting on my brain, literally. Like, how do you get it? Like, y'all aren't lifting it by yourself. How does it get on the ambulance and on the?
So on the ambulance, we have a power load system.
Okay.
And thank goodness.
Right.
Because there was a day we did not.
Because you're going from a stretcher, theoretically.
was
You're
one day.
getting the baby and the isolates on a transport stretcher, and then.
Yeah. And so it loading in the MICU, it's a button push. It picks itself up, and then you just slowly push it into place, and it locks in. On the
Kind
helicopter,
of like automatic doors on your minivan.
garage-
Like,
yeah,
kind of.
garage
Okay.
door.
Sure.
I got you. Yeah.
In the
Okay.
helicopter, it's a 3-person process. So 2 people do the heavy lifting. 1 other person lifts the wheels and kind of guides you into place.
Hence the need for arm day.
Yep.
Yes.
Okay, so in a minute, we're actually going to talk about some actual trips y'all have been on. But first, I want to mess with David a little bit.
Here we go.
And we're going to see if, now I'm going to need your help because I'm literally making this stuff up. Okay. But I'm going to see if David can guess if some of the things relative to the work you do is fact or fiction. Okay. So I'm going to give him a statement. He's going to have to work through it in his head if it's fact or fiction. And then y'all get to, what do you call it? Fact check or whatever. And
I hope it's math.
yeah, because I don't honestly know the answer. So okay, here we go. We're just making this up.
Okay.
Like lay people, because we are. Okay. The flight suit, okay, fact or fiction.
Okay.
The flight suit is flame retardant and is only used on flight transports.
I would imagine that it would have to be flame retardant just from a safety perspective. And you all are modeling 2 lovely versions here for us today. I would say that is fact. You both look like you could get in a helicopter right now and hopefully not catch on fire.
That is actually partial fact, partial fiction.
Uh-oh.
So we do wear these in the helicopter, but we also wear them on our ground trips. So this is our uniform for any kind of transport. And the reason for that is we used to wear just scrubs or whatever when we did trips, our ground trips. And, it was just kind of a, then if you got a flight, you had to change. And, so we just decided several years ago, we're going to keep it simple. And so we wear these lovely garments all the time.
It's
Time
like
saving.
an adult onesie.
Yep.
It
Kinda
is
like
exactly
it.
like a onesie.
Yeah.
Do you call them the forever lazy? Probably not. You guys are not lazy at all.
We do call
Is
them the
it-
adult onesies, though.
Is it hot? Like it looks so hot.
Freezing in the winter, sweltering in the summer.
How is it freezing in the winter?
It's thin.
They're
They're
They
thin.
actually are thin.
Really?
Like if you hold one up to the light, you can see through the back of it. I mean, they're thin.
I would not have guessed that.
Yeah,
They
but
look hot.
They are
So
very hot.
if you have more than one suit, and we all do, you'll have one that fits better than another one, and that's the one you wear all the time. It gets washed. It gets thin. That's the one you wear in the summer.
Uh-huh.
And then the one that's newer and thicker, you wear that in the wintertime.
I love
You have
it.
your own process.
Yeah.
Oh, yeah.
Okay, fact or fiction?
Okay.
The helicopter will not fly if there's rain.
I would have to imagine that that's false. I think a helicopter could fly in the rain, but there's probably other factors that would ground a helicopter.
We do fly in the rain. It used to be that we were only allowed to fly when there were visual flight rule conditions.
Meaning that you could only use your
You had to
eyeballs.
be able
not
to see where you were
Yeah.
going. We will not fly in thunderstorms. We don't like to fly close to them. That's dangerous. Recently, we became an IFR rated program.
What's that?
What?
Instrument flight rules, so we can fly with less visibility.
Just using
No
your
storms.
dashboard instruments.
Using all the instruments and the autopilot, and a lot of additional training for our pilots.
The helicopter has an autopilot. How cool is that?
Okay, fact or fiction. When in flight, a helicopter burns more than the average full tank of gas in 15 minutes.
This feels like an ACT word math problem. Okay, so in flight,
Well, think about it.
15 minutes.
Yeah.
Okay, average tank, what is that, like
12 to
15?
15, yeah.
Okay, 12, 15 minutes. So that's like, what, 60? I have no idea. I mean, I'm going to say that's fact.
Yeah, that's pretty true. I think it's around 80 gallons an hour.
80 gallons an hour?
Wow. Y'all get your gas at Costco?
You waiting in line with everybody else pulling the helicopter up?
They got a deal on
That's a
gas.
ton
I'm
of
just
fuel.
saying, that's a lot.
Well, now I can understand why time is important for you all.
Yeah.
For real. Oh my God. Okay. Fact or fiction. The transferring facility gets to pick whether the patient is transported by ground or by helicopter.
The transfer, so that's where the patient is being acquired
They
from.
get to say.
Well, I'm going to say that's false. I feel like it's up to Judy and the other team here with their fancy triaging methods.
Actually, a little bit of both.
Oh.
Because as Dana said, we sometimes parents can, if a parent right away says, I don't want my kid in a helicopter, there's nothing we can do, because if we did fly the team there, they wouldn't let their child come with us because they said no. And then sometimes physicians are like, I think they can just go by ground. So it's a little bit of both. Primarily, though, there's not a lot of pushback when we recommend a certain mode of transportation, but there are those two limiting things that can prevent those from happening. So it's a little bit of both.
Interesting. Okay, last one.
Okay.
Then you're off the hot seat. Fact or fiction. When we are transporting newborns from facility to facility, the baby travels with a transport blanket that has had contact with mom.
I'm happy to say that I know the answer to this, and I can't wait to hear the explanation. I know that is true.
Actually, we have to give credit to Katie Francis, who was one of our transport nurses. And she is the one who came up with this idea. So over the years, we would try to do various things. There was a time when we had Polaroid cameras in our bag, and we would take a picture.
Before the time of iPads?
Yes. Yes. I'm really dating myself.
Yeah.
I like a good Polaroid camera. I'm not going to lie.
Hey, they're coming back.
Yeah. I know.
So, we would offer to take a picture of baby or baby and mom or baby and parents for them to keep with them for us before we left. But Katie is the one who came up with this idea of a blanket that was specifically for transport. And so we've been doing this for many years now, and it is just a very small blanket. It's embroidered. I think it says my transport blankie on it. And what we do, we always, when we transport a newborn, we always take the baby to wherever the mother is. So if she's still in labor and delivery, or if she's in her room, we always take the baby to see the family before we leave. And so, we go over a bunch of things, and then we always take the blanket and give it to mom, and a lot of times even dad too, and say, put this on your chest for a few minutes, and then we'll take it with us and put it in the isolate with the baby, and it will have your scent on it. And the families love this, and I've even had a few where the blankie got lost somewhere in the process in the NICU, and they'll be like, can we please have another blankie? And so, we will give them another blanket. So it's a fantastic thing that we do, and I love that we do it. So yeah, that is true.
Too. Are there any other, I don't know what to call them, rituals, or I'm making the sign of the cross. I don't know why, but Are there any other, like, before you go out on a transport, you always do this, like, or anything that's specific, like either individually, like as just for yourself, or like as a team, like that, like the blankie, you do that with every newborn,
Yeah.
Is there anything else?
I just always make it a point every time I take, whether it's a newborn or a patient, the last thing I always say to the family is, we will take good care of your baby, or we will take good care of your child. You just be careful coming. And I think, I mean, you think, yeah, it's common sense that of course we're going to take good care of their child. But as a parent, I think just hearing that, I think just really makes them say, okay, we got this. And, and then telling them to be careful, because, especially when we're coming a long distance and they're driving, obviously we're going to beat them here. And, they've got a long drive. And I always try to support, tell them, if possible, don't be the one to drive. Let someone drive you. Or, even like when we're going by ground and it's a long distance and, they're like, well, can we ride with? And be like, well, you can, but you're going to ride up front away from the patient. And so maybe you and dad should ride together so that you can keep each other company. And, and a lot of times they will decide to do that because they know, yeah, well, if I'm not going, my child isn't going to be able to see me or interact with me, then maybe it is just as well if I go in the car. So that is one of the things that I always do. I always make sure I say that we will take good care of them. So I don't know about Jeff.
I think with the neonates and the new moms and dads, most of us, despite whatever terrible thing has happened or is happening to their child, we always try and include the congratulations. And even though they're having a bad day, they still deserve the recognition of, new parents, moms and dads. And so I think that's important.
Okay. And I'm sure as you're even just thinking about those moments, there's certain transports that are running through your head. So this is probably a big piece of what I wanted to get to. You have many years of experience, many transports under all of your belts from different perspectives. I would like to start, and we're going to have each of you share, what is your most memorable transport?
I can start. I have many memorable, I guess I would say, but one that kind of speaks to when JP was talking about physicians and how how it's a nurse presenting to a physician. I just remember I got called to an outside hospital. It was a neonatal. I got there and this patient was not doing well at all. It actually turned out to have a perforation, like an opening in their stomach, and it wasn't recognized right away. But I was young. I don't even remember how old I was, but less than 30, and the pressure that this doctor just wanted us to get out. Like, we're good. Just put the baby in your isolette and go. And I just remember talking to one of my neonatologists that was here, and I was just like, something's not right, nothing's not right. And so we tried to do everything before we left. And when we left, the patient coded in the ambulance, the rest of this little newborn, and turned out that the perforation had just gotten larger and larger. The tube, the endotracheal tube, so their ventilator became dislodged. And we had a decision to make right then. And again, I guess bad things happened to me when I was really young. And I was like, wait, I'm too young to make these, to have to make these decisions. But we had to decide, do we go back? Do we not go back? And so we ended up going back because we were closer to that facility. And in the ER and just talking to that physician who was very belittling to me, like, do you even know what lungs are? That was that whole kind of thing. And he wanted me to do a specific, give some fluid, whatever, took me by my arm over to the x-ray just to show, what was going on. And just me having to keep a calm, nobody likes to be yelled at or whatever. And just to be able to be like, it's okay, you're going to get through this. But I think what was so memorable about it was he was talking to our physician here who was saying, no, this is what I would like, what I like. And when I left, he told me and the respiratory therapist that I was with, he was like, I don't want you ever to come back here again. And I remember thinking, oh my God, what did I do wrong? What did I do wrong? And then I had to go back the very next night and he was there. So it was, but it's just that whole time of like you said, sometimes you just have to bite your lip and be like, this is horrible that this is happening to this baby. We're trying everything to do, to help the baby. And just dealing with the physician, I mean, it's very difficult. And the autonomy that comes with the job, while it's fun and good for some things, you get to use your critical thinking skills. That's probably my least favorite. I guess I shouldn't have said that was my most memorable, but my least favorite. But just knowing that you had to keep your calm the whole time and be like, yes, you're yelling at me, but it's going to be all right.
Well, and like you said, it's kind of on the job training,
Yeah.
Initiation by fire, but
Exactly.
you learn how to, I don't want to say stand up to that, but stand within that.
And it's how to
Yeah.
address that. And when I got back to Glennon, I remember Dr. Mantich, God love his soul. He was here, and him and Dr. Keenan were just like this. It was almost like two dads giving me, the biggest support and just encouraging everything I did and everything I did right and things like that. So that's like one of my standouts, that I tell that story to new people as giving examples of, it's not always you go and everyone's super happy all the time, or, they really want that child out of their facility because they're not comfortable taking care of them anymore. So I use that as a teaching point a lot, or I did, I guess, when I was still on transport.
Yeah. And maybe that's why
Maybe.
that happened. You never know. Miss Dana?
I honestly have too many that I can, but I think the ones that I remember the most are the ones where we don't bring a patient back. Because those are situations that, we know we're going into a bad situation. And when we get there, the referring staff, they are looking to us to bring our expertise and our knowledge to hopefully, to save this patient. And there are times when it's just beyond our control. And, the situation has pretty much already claimed itself. And we're just there basically to say, yes, there's nothing more we can do. And I think those for us, it's never a good feeling to come back without a patient. But I think just the comfort that you bring to the referring staff as well as to the family to say, okay, I think really, truly everything was done. And now here are these people that have this knowledge and have this experience, and they're confirming that there is nothing more we can do. So, even though I don't want it to sound like that happens all of the time, we for the most part, we are able to bring our patients back. But I think those are the ones that just always stand out to me, because then we have to switch modes. And now I have to think about, spending some time focusing on that referring staff. They are not used to pediatric death. They are not used to neonatal death. And so having to help them process what has just happened. It's not like we just walk in, pronounce the patient, and turn around and leave. We don't. We make it a point to stay, debrief with the staff, and try to answer questions, help them with, any kind of, presentation of the patient to the family, be there to support the family when they come in to see the patient. So it's a very different skill set. And I just, like I said, I think those are the ones, I can think of several right off the top of my head. And, where I feel like in a small way, we did still make a difference. It just was a very different kind of experience.
The average day, there's a lot of thank yous, there's hugs, there's handshakes. And that's every day. And, for that day, that would stand out. Will I remember it next week? I remember I had a good time at work, but I probably won't remember names, might not remember faces. And I don't want to get dark because it sounds like we all have terrible stories.
You should have said a happy, memorable. That would have sent us down.
I'll make mine. It's dark, but at the end, there's a happy ending.
I said memorable. I
It
didn't
is
say happy.
memorable.
Well, I didn't
I
say
don't
what
wanna
was
be
your most successful.
dark.
I said memorable.
I had the opportunity one night, or one shift. I was working a 12-hour day shift. Somewhere in the middle of the day, I was asked, "Do you have a passport?" And there was a patient, in the ICU, the PICU. He had been brought here from another country, and he had an uncurable condition that was going to be his demise. There were circumstances that I don't know the details of, but his father was unable to travel with him. So Cardinal Glennon worked with another charity, and we were able to take him back to his home country, which was Antigua, which we left sometime after dark on an airplane from downtown Cahokia, the airport. Flew to Fort Lauderdale. We had gas and food. Next stop, Puerto Rico. And then somewhere around daybreak, we were in Antigua. And we took him to the ICU in that town, and there his family was able to be bedside with him. So, it's Cardinal Glennon taking care of the whole family. In the end, he wasn't curable, but he got to go home to be with his family, and his family could be with him.
Right.
That's the longest trip I've ever done, time-wise and miles.
A little bit more than 250 miles out of the radius.
Yeah.
That was a lot of gas.
Right. And so, you asked earlier about nurses and your partners. I had a partner, Rebecca Dagenhart, and I did it, and she's a fantastic nurse. We had to take turns napping on this flight. And so we would, 30 minutes or so, and then you'd wake, and then it was your turn. Because this child needed constant attention. And it was challenging to go so far and to be awake for so many hours.
Well, and that's your goal, right? The family, I think, is waiting because they want their family to be together when he passes. And so you have to take a critically ill child that far and assure to the best of your ability that they get that opportunity, right?
Yeah, there were all kinds of emotions because, you get to hang out with the child and mom for basically a whole day. And then, when you leave, things are going to change. And it's going to be a sad day for that family.
Yeah.
But at least they were together.
Mm-hmm.
Yeah.
Mm-hmm. Dr. Peter, what about you? You're involved, maybe not in the vessel, but you're involved with all of these, right? So
I'll give you three quick ones.
Good. We get three.
Well, only because I can't decide.
I love threes.
It was early on in the evolution of the team, and I was just getting familiar with the way, the aircraft and ground ambulances and stuff like that. And so I asked the people at the time who were our medical providers, could I ride along with you guys on a trip just to see how you guys do this stuff? And we were flying in an older aircraft, one we don't fly anymore. It was a smaller aircraft. We flew to a community hospital, and we landed, and the helipad was surrounded by trees. It was a relatively big field, football-sized field, but trees around it. And it was a hot day. And so we're leaving. He says, "Get yourself strapped in." So I put my seatbelt on. He says, "We're going to have to take a run at it." And I'm like, I didn't know what he was talking about. I'm like, "What are you talking about? Run at it? Oh, just hang on." So he lifts, and it's hot, and helicopters don't do well when it's hot. The air's denser. They don't. So he lifts a couple feet off the ground, heads down to one end of the field, just about to the trees, turns around, hits the gas, flies towards the other end of the field, and we managed to come up over the trees.
Thanks.
And I was like, did we just do that? Do we do this a lot? Well, it was a hot day. There was another trip where I was on. This was when I was actually, the team was active. It was a transport nurse who we were, as I recall, flying over the National Forest in Missouri, Mark Twain. So there's not a lot there. And if you've ever flown over those places at night, there's not much there. There's no lights. It's dark. It's very dark. And we're flying, and so there's no place to really land when the pump goes out that's infusing a drug called dopamine. And it's the drug that's maintaining the patient's blood pressure. And couldn't get the pump to work, and we basically ended up having to take the syringe out, and we took turns just kind of giving a little push. Little bit
titration
to titrate
Right.
to keep the patient's blood pressure up, and we just had to keep doing that till we got back to St. Louis because we couldn't get the pump to work.
So how long?
Oh, that was probably about a half-hour flight.
Wow.
Just
You got to be the manual pump.
It's the longest 30 minutes ever.
Yeah, from a nursing standpoint,
Yeah.
what that was like. And then the last one was this was one, as a medical director, was really tough. We were flying a team over the Air Force Base over in Illinois, and somewhere in the middle of all this, and whenever you do that, you have to get special clearance. When when they fly over the Lambert or the Air Force Base, you have to call ahead and get clearance.
It's restricted airspace.
Restricted airspace.
Yeah.
So apparently they're flying over the base, and according to the team that was on there at the time, suddenly you hear an expletive shouted out by the pilot, and a hard bank in the helicopter, and a jet comes flying out of the Air Force Base and miss them. So I meet the team on the ground when they land back at Glennon, and a sobbing transport nurse who just really thought she was going to die that day. So that was, and she's a great nurse. She got through it. She worked through it. She no longer does transport, but she was able to continue. But that's the kind of stresses these guys go through sometimes. This kind of stuff that they have to work through.
I know, Jeff, you mentioned that you may have like several in a day, and you might not necessarily remember like faces or names, but do any of you have any like reuniting stories of like with families that you've helped in the past that like maybe because like, hey, you were on the ambulance that took my kiddo, or have you ever had any of those experiences where you were able to reunite with a family you helped?
There are families that have kids with chronic conditions that we see over and over, and I'm sure for them it's comforting I hope it's comforting that you get the same people that you're familiar with, but I don't have any specific.
I had an interesting thing that happened probably within the last 6 months. I received a Facebook message from an individual asking if I was the transport nurse that transported an abandoned newborn about 24 years ago.
Wow.
From X hospital. And, with social media, you're always kind of like, oh, I don't know if I really want to answer this person. And so I just kind of ignored it. And then, but I told my husband about it. And he was like, well, you did it. And they had the proper details. And I said, I know, it just kind of freaks me out. So this individual had offered a phone number to call, and I didn't want to do it, but my husband called him. And it turned out he was the cousin of this child who I had transported. And he was really wanting to meet me. And, I told my husband, I said, I don't know. I kind of am not sure about this. So, we basically left it with, here's the contact information, and should you want to meet, but I just want you to know he did well. He's productive member of society. He's, so that was, I think a very much, this is our why. This is why we do this. So that kind of thing, I think social media is amazing. It can, does amazing things. We all know it can have its negative side, obviously. But just, I don't know how they found me. I don't know how. I truly, I don't know. But
wow.
Yeah. So
That's wild.
That's pretty amazing.
And I think how Jeff said you run into those patients that have chronic conditions. I think I shared this story with you before. I picked up a little girl who's now 10, I think 10 or 11, super sick, was in our NICU for a long time. And I was never on social media. We are always encouraged, don't friend any, patients, whatever. And I had a mom do the same, reach out to me, and I immediately knew who she was. And I had that second, like that gut feeling, like, do I really friend her? Do I not friend her? But I did friend her, and I would see them a lot at some of their appointments. And it's such a good feeling to know, 'cause this girl was so ill. I mean, she was really not supposed to live. And she's now 11 and she's thriving. And, I can follow her I see her on Facebook. The mom will always say, I remember when you picked her up at the hospital, and just, she was so sick, and to kind of watch what they go through. And I would see them at appointments, run into them in the hall. And the fact that they still remembered, that it's just,
Right.
it boosts your why for sure. It's
Right.
definitely a good feeling.
So, Dr. Peter, let's wave our magic wand. Let's pretend that we are fully staffed to where we want to be. Where would you like to see this program go in the next 5 to 10 years? Is there like a bucket list, or where is there like, if you could do what you wanted to do or meet what you think is a need that's not met with the talent of this team, what would that be? Where would you like to see it go?
In the perfect world, I'd have nurses that got 3 years of med-surg experience. They went on to critical care training. They got years of experience in that, and then they came to work for us. Like, it ain't going to happen. It's a different age. People have different goals in life and things. So that's probably not. Probably what I'd like to see is, and we've tried various different ways to best serve the population out there. And we've tried, different locations for the team, different configurations. And that's sort of just an ongoing process, is to find sort of that right mix of people and locations to serve the majority of children that need our care.
Well, I'll say, in current state, short-staffed or whatever you want to call it or not, you guys are a dream team, truly. I would want you to be my kids' team if I ever needed you. Hope I don't. When I say the words Glennon Factor, what does that mean as it relates to your work in transport?
So since I don't do transport anymore, so my focus now is on the Access Center. Mine is always just going back to the reason I started here. When I worked in the NICU, the mission, it was so lived and you felt it every day. And so with my nurses, I try to do the same thing. Like, I'm very open. I encourage open relationship, call me when you need me. Can I reach out to you whenever? I mean, I'm very transparent with my team. And I think that is, we hear people say, there's just something about Glennon. I walk in there, I feel this. I felt it the entire time I've been there. And my husband is so funny, because I would tell him some stories about how, I remember this police officer years ago, over 20 years ago, who used to come to the ER to get an injection. I can't remember what he had, but he just needed someone to give him his shot. So some nurse would give him his shot that he needed. And I just remember him saying, I just can't express enough how much whenever I walk through these halls, I feel, this certain way. It feels like a family. It feels close. It doesn't feel sterile. We are very, very fortunate to have 2 level 1 pediatric standalone hospitals. Like, I think we're the only, and we are so fortunate for that. But there is definitely a difference at Glennon. I mean, it's like hard to describe for me, but it is so in my soul. And so I think my girls, I think that's one of the reasons that they came, was just me talking about it. And it is a family for me outside of my own personal family. Not that has to be that for everyone, but for me it is. And so I strive every day to project that to who I deal with.
I think for me, my biggest Glennon factor is our families. I just think we have so many opportunities to make a difference. And I think overall we do. And, because you're not just taking care of that child, you are taking care of the whole family. And that is very unique to pediatrics. And, I just feel like it can be challenging. It definitely can be challenging. We all know we have challenging families, but I just feel like if you can make a difference to them and not just to the patient, then you've done a good job.
For me, I get to come to work, and so many of the kids, we get to play. I get to be a kid for the half hour, 2 hours that we're driving down the road or we're flying. And for me, that's great. It's not work when that's going on. And if we get back here and that kid tells mom or dad that, it was a good time, that's good for everybody.
It's that recurrent theme or comments we hear from referring hospitals just about how they felt so involved in the care and how they learned from our team. They're just a giving group. I mean, they go out there, you just think about, there's times when you wouldn't blame them for saying, let's just get out of here. Let's get this kid packed up and let's go. But they don't. They take the time to get the referring hospital involved, get the staff involved. And I mean, it's not only just good for referrals and things like that, but maybe it's going to translate into the next time a sick kid will come into that ER, they'll remember those skills that they learned from the transport nurses, and they'll do a better job. So it's hearing stuff like that really sets the place apart.
Well, we have thoroughly enjoyed having you guys here. Any closing words? Anything else that you guys want to share with anybody?
Well, thank you for having us.
Thank you.
And,
Thank you.
It was a privilege to get to be here and talk about what we all love.
Well, the thanks are all on this end of it, because we appreciate everything you all do at the hospital and the time and care you put into it all. We hope you enjoyed this episode of the Glennon Factor. Make sure you follow the Glennon Factor and leave us a review wherever you get your podcasts. Visit glennon.org if you would like to learn more about how you can support Cardinal Glennon kids. And while you're there, feel free to share any feedback or episode suggestions on our podcast page. The Glennon Factor is recorded and produced by SSM Health Cardinal Glennon Children's Foundation.